This week on the BackTable podcast.
PSA density is, I think, a very important biomarker. Going back to just PSA is actually the only biomarker that's really approved by guidelines for active surveillance monitoring, and PSA density is an important factor in many, many studies, active surveillance studies. It's been associated with progression on surveillance. Usually the cutoff of 0.15 is used, but other cutoffs have been studied as well. In grade group 2 patients specifically, studies have shown that those patients, if they have a high PSA density, they're more likely to have adverse pathology at radical prostatectomy. So I definitely take into account PSA density when counseling patients. Now, I don't necessarily use it as a complete exclusion criteria. I'm sure we all have a few patients with high PSA density, but I will definitely wonder, is there more volume of tumor that's not really well sampled? So do I need to repeat an early biopsy? I will monitor them more closely.
Hi, everyone. Welcome back to BackTable Urology. Today, I'm really excited to be joined by Dr. Claire de la Calle, who's an assistant professor of urology at the University of Washington. Claire, thanks for joining us. I'm really excited to talk about active surveillance for intermediate risk prostate cancer. But first, why don't you tell the audience a little bit about yourself?
Hi, thank you so much for having me. I am an assistant professor at the University of Washington and Fred Hutch Cancer Center. My practice is mostly prostate cancer and some bladder cancer as well. I dedicate 50% of my time to research, and all of my research is around active surveillance. I'm highly interested in working on biomarkers to better identify patients that are good candidates versus not good candidates for active surveillance. And this is a very important topic for intermediate risk patients on active surveillance. So I'm really excited about the conversation we're going to have today.
Yeah, I think it's really, really relevant because it's becoming a common clinical scenario. We've seen active surveillance evolve from a strategy that initially was reserved really exclusively for patients with low-risk prostate cancer. But I'd argue that especially, over time, as we've been able to learn from your work and others out there who are looking at risk stratification and more accurate diagnostics, that I think, it is a viable option for select patients who have specifically favorable intermediate risk disease. And we are seeing a lot of specialty organizations and guidelines actually include recommendations to consider active surveillance in those scenarios. So as we're seeing this sort of paradigm shift, I think I would love to hear more from you about the current evidence that we have out there for active surveillance in patients who have intermediate risk disease.
Yeah, definitely. I think it's really important to first start by looking at the PROTECT data to understand the long-term outcomes of untreated versus treated localized prostate cancer, especially because PROTECT is one of the few randomized clinical trials that we have in localized prostate cancer management. And as you all know, the study randomized around 1,600 men, and 24% more or less of those had intermediate risk disease. And the patients were randomized to active monitoring or radiation therapy or radical prostatectomy. And at 15 years of follow-up, there's really no difference in all-cause or prostate cancer-specific mortality between all three groups, which is fairly surprising when thinking about cancer. Now, the rates of metastatic disease were significantly higher in the active monitoring group, around 9% versus around 5% for both the radiation and surgery groups. But active monitoring is very different from active surveillance. Active surveillance is, of course, a much more intensive monitoring of the cancer, and I think that's important. Patients will often ask me about this trial, and that's something I think needs to be stressed. Now, from the active surveillance literature specifically, Dr. Guillaume Ploussard and his colleagues published a great systematic review and meta-analysis specifically comparing the outcomes of low-risk active surveillance patients and intermediate-risk active surveillance patients. And they basically showed that in an unselected intermediate risk group, those patients had greater risk of metastases and a greater risk of prostate cancer-specific mortality. But the key word here is unselected. They focused their analysis then in the subset of patients that only had grade group 2 prostate cancer. And in that subset, metastasis-free survival was similar when compared with the low-risk patients. So it really means that appropriate patient selection is key when considering active surveillance in an intermediate risk patient.
Yeah, that's right. And I think that brings me to my next question really well. It's a nice tee up. I wanted to cover a bit about what selection criteria can help us better risk stratify patients within that intermediate category, whether, someone is appropriate versus not. But I think there's a lot to cover here. So let's start just with tackling a bit about this heterogeneity that we see within favorable intermediate risk disease. Tell me your thoughts there.
Yeah, just like you said, patient selection is so important for intermediate risk patients. It's more important, I think, than for the low risk patients, because these intermediate risk patients are more likely to develop metastases and die of prostate cancer. And like you said, it's a very heterogeneous group with a very wide spectrum of disease biology. In fact, when a patient with intermediate risk walks into my clinic, it could be a patient with indolent disease or lethal disease. Really, every end of the spectrum is represented in this group. And before I even think about selection criteria for active surveillance, I really want to know, first of all, had they had the appropriate workup? And I think it's premature, for example, to consider active surveillance in a newly diagnosed intermediate risk patient if they haven't had an MRI and followed by a targeted biopsy. We know that MRI does lead to less misclassification of prostate cancer. And I also, of course, I would like to have a fairly recent PSA, know what the PSA kinetics are, the PSA density, ideally a thorough review of the pathology, ideally with a GU pathologist, to know what the type of pattern 4 is, for example. And of course, I also want to know the patient's comorbidities, what their life expectancy might be, their family history and genetic background, and their personal, cancer management goals as well.
Yeah, absolutely. I mean, I think it's a no-brainer. Even a decade ago, when active surveillance wasn't quite as widespread, I shouldn't say it wasn't quite used as widely, we were still considering things like active surveillance or just observation in patients who were sick or patients in whom treating the cancer wasn't within their goals of care. So great point there, and we should call that out. But I'm curious, for the healthy young patient who would be a reasonable treatment candidate, are there specific things in the pathology report that you are looking for?
Yes, there are a lot of things. I think one of the first and most important things to look at is the volume of Gleason pattern 4. So we're talking about intermediate risk patient. I'm assuming that they're grade group 2. And so for those patients, the amount of pattern 4 we know is critical. In fact, studies have shown that with each decile of percent pattern 4 or each additional number of positive cores, then the risk of adverse outcome increases. And we know that patients with low volume grade group 2 disease and really minimal pattern 4 have outcomes that are approaching or essentially the same as patients with low risk disease. Now, although we know it's very important, at the same time, there are so many questions around volume of pattern 4 that still need to be answered, or at the very least, some sort of consensus, I hope, eventually will be reached, because we don't really know what is the best way to quantify volume of pattern 4. Is it the percent Gleason pattern 4, the maximal percent Gleason pattern 4 involvement, the length of the pattern 4, the maximum length or the total length? There's so many different ways one can do this. So that's one important question that we need to address still. Then there's how to account for targeted cores. I really think we tend to overestimate tumor volume in patients with targeted biopsies, especially as, for example, the European guidelines for patients, with their undergoing their first biopsy. So we're talking about patients with no diagnosis of prostate cancer, now recommending targeted biopsies only. Providers are now more and more doing that and maybe saturating the area around the target. That certainly can lead to volume overestimation, or you probably see in your clinic patients that have fusion biopsies and then systematic biopsies, and essentially all the cores in the location of the target are positive as well. All those nuances, I think, are really important when estimating tumor volume. And of course, what is the cutoff of pattern 4 that we're comfortable monitoring? For grade group 2 patients, they already have pattern 4. Are we really waiting for grade group 3 or higher? So we often call extreme upgrading or extreme grade classification in active surveillance studies. We know that grade group 3 patients have way worse outcomes than grade group 2 patients. So I don't know that grade group 3 is really the outcome we're waiting for, especially those patients. Not only do they have worse outcomes, like I just said, they also need more intense treatment. If they have radiation, they're going to potentially need hormonal therapy. If they undergo surgery or radiation, they might need secondary treatments, salvage treatments. So those are all also outcomes that we should try to avoid for active surveillance patients that could have treated their cancers earlier on in the timeline of their cancers with potentially less side effects or treatment toxicity. So that is also very much something that we need to continue looking into and hopefully reach some sort of consensus in our community so that we can better counsel our patients.
Yeah, great point. We're going to talk about your surveillance protocol and monitoring in a moment, but I want to just spend a minute going back to something you said about estimating disease volume. Now, let's say in this patient who's presenting with a new diagnosis of prostate cancer, you're considering active surveillance. Here in the US, I think we're still mostly doing systematic plus targeted biopsies. So let's say they present that way. Do you look at the size of the lesion on the MRI? If, for example, all of the targeted cores were grade group 2, there were maybe none or maybe just a small amount of grade group 1 in the systematic biopsy. Is the size of the lesion on MRI playing a role here?
Yeah, I use the size of the lesion to help me understand if I did good targeting or if a good targeting was done. So if the lesion is 2 centimeters and I only have a few millimeters of cancer in my cores, that certainly worries me that the targeting wasn't well done. And we know that happens very regularly. So I think that's very helpful. In terms of actually using the tumor volume on MRI for active surveillance, we don't really know. I mean, even studies that just look at PIRAD score, there's a lot of discrepancy, I think, still in the literature. And in patients, even patients that have negative MRIs can still progress on surveillance. So that very much is a question that needs to be answered. But in practice, if I'm seeing a lesion that I've biopsied and I find cancer, so now I can call it a tumor to the patient. If that tumor is clearly growing on serial MRIs obtained during surveillance, it's not something I can ignore. So do I use it? Yes. Do we need more research to prove that it's helpful? Yes.
Yeah. What about PSA density?
Great question. PSA density is I think a very important biomarker. So just going back to just PSA is actually the only biomarker that's really approved by guidelines for active surveillance monitoring. And PSA density is an important factor in many, many studies, active surveillance studies. It's been associated with progression on surveillance. Usually the cutoff of 0.15 is used, but other cutoffs have been studied as well. In grade group 2 patients specifically, studies have shown that those patients, if they have a high PSA density, they're more likely to have adverse pathology at radical prostatectomy. So I definitely take into account PSA density when counseling patients. Now, I don't necessarily use it as a complete exclusion criteria. I'm sure you have as well in your clinic a few patients with high PSA density, but I will definitely wonder, is there more volume of tumor that's not really well sampled? So do I need to repeat an early biopsy? I will monitor them more closely.
Yeah. And again, a great segue to my next question for you. You talk about early biopsy. I want to hear a little bit about your surveillance protocol for these patients. Does monitoring look different in patients with intermediate risk disease versus those with low risk disease?
Yes. And our guidelines do say that we should tailor the monitoring to the patient. And so intermediate risk patients, we know are higher risk than low risk patients. So we definitely should do it. Now, how we should do it, again, no consensus. So there's a lot of different protocols out there. I'm lucky to work at University of Washington where the Canary Pass study is ongoing. So a lot of my patients are on the PASS protocol. My intermediate risk patients, I am following more regularly and more intensely. Definitely PSA testing every 6 months at least. Sometimes I do every 3 months if I'm worried or if I really want to get a better idea of what their PSA kinetics are. I think a confirmatory biopsy is key, especially in intermediate risk patients. And timing of that confirmatory biopsy is really going to be on how worried I am. So if I worried, like I said before, the PSA density is high, maybe they haven't been adequately sampled yet. I'm going to do the biopsy either pretty much immediately or within the first 6 months, basically. Otherwise, most of my patients are going to get their confirmatory biopsy at 1 year. So 1 year after their initial diagnosis. Then the frequency of this, what I would call surveillance biopsies, so all the biopsies after the confirmatory biopsy, that really is going to depend on the patient. And so for my intermediate risk patients, I tell them it's going to be anywhere between every 1 to 4 years. to start, and we'll decide based on other factors like the PSA, the kinetics, the PSA density, the MRI. And eventually, if they really don't have progression for many years, I think it is completely reasonable and in fact important to consider de-intensification of that protocol. And because a lot of these grade group 2 patients do have very small volumes of pattern 4 and have cancer that are essentially biologically similar to a low grade, it does have low grade cancers. It does happen that de-intensification needs to be considered. A baseline MRI, like I said before, is definitely needed. The use of serial MRIs and the frequency, that still very much needs to be clarified. Personally, I like starting with MRIs every 2 years. A lot of the guidelines do say that we really shouldn't be getting MRIs more regularly than every 12 months unless clinically indicated. I think it's rare to see a major difference in such a short time frame. And I also de-intensify that frequency, meaning I get them less and less regularly if the cancer is clearly not progressing. And then in terms of DRE, our guidelines do say that we should not do DRE more than every 12 months. I do admit that I am doing DREs less and less regularly, especially since COVID. We started seeing a lot of our active surveillance patients through telemedicine, which I think is great and actually helps with compliance and keeping in touch with the patient and not forgetting about the cancer. And I think the MRI is a great replacement for DRE, but for sometimes specific reasons, I will do them, but I don't have like a specific frequency for when I do them.
Yeah, I think that all makes sense. I mean, I think what you said about MRI specifically is an important point. Often I'd say nearly 100% of the time, I'll do an MRI before my confirmatory biopsy for obvious reasons. But a lot of times, I'm sure as in your clinic, I might be seeing a patient who's been diagnosed elsewhere, and I don't have the MRI reviewed by our specialized radiologists, which we know can change the read. But I think it's a good point to remind ourselves that we really shouldn't be doing it more than every, 12 to 24 months after the initial confirmatory biopsy. What about your triggers for intervention? I mean, you touched on this briefly, and I know that there's not great consensus in the guidelines in terms of what we're looking for, but practically in your clinic, what do you generally use to guide that decision?
Yeah, I think it's important to not use only one clinical factor when making that decision, really looking at the entire picture. And that's very much stated in our guidelines as well. I look at everything. I look at the PSA kinetics, the progression PSA density. Is there an increase in the amount of pattern 4? Is there suddenly new presence of cribriform type pattern 4 or intraductal carcinoma, new presence of perineural invasion? Definitely progression of tumor volume on biopsy or MRI, like I mentioned earlier. And certainly a change in stage as well. So suddenly concern for extraprostatic extension, for example, on MRI. All of those things will make me want to consider treatment much more seriously. And then sometimes a genomic classifiers will also help me in deciding on need for transition to treatment.
Yeah, and you bring up one point that I don't think we covered earlier, so I'll just go back and ask you that now. Intraductal obviously would upgrade the patient automatically, but for you, is cribriform morphology an automatic disqualifier at the initial biopsy?
Yeah, great question. So the type of pattern 4 is we know very important, especially large cribriform. There are studies that have looked at the sensitivity and specificity of identifying cribriform or intraductal on biopsy. And unfortunately, the sensitivity is low. So if you don't see cribriform, it doesn't mean it's not actually there. But the specificity does seem to be quite high for both large cribriform and intraductal carcinomas. So when I see it, I really believe it. And we do have several studies that have shown that patients with large cribriform type pattern 4 and intraductal carcinoma definitely have much worse oncologic outcomes. So in my practice, it is an exclusion criteria for active surveillance. Now, the problem is that there's a lot of discrepancy in how cribriform is reported. Some pathologists don't report it. Sometimes small cribriform is reported versus large. And small cribriform, what is the significance of this on biopsy? How accurate is it? Is it as specific as large cribriform? Personally, I don't think so, although I think we need to do more research on these active surveillance with small cribriform. So I do have some patients with small cribriform that I monitor closely, that I do monitor. But large cribriform and intraductal, I do consider exclusion criteria for active surveillance. And I do want to mention one more pathologic feature, and that's perineural invasion. Similar to cribriform, there's a great variability in how it's reported. Some pathologists don't report it. There are different definitions of what perineural invasion is. But there are several studies that suggest that if you have perineural invasion and grade group 2, you're going to have more adverse pathology at radical prostatectomy. At the University of Washington, unfortunately, we do not report perineural invasion on our biopsy reports. We felt like it was causing a lot of patient anxiety. This was many years ago, so maybe that will change back to putting it in our biopsy reports. So I don't use it as an exclusion criteria because I think the evidence is not as strong. But when I do see it in an intermediate risk patient, I just consider it like an additional negative prognostic factor against surveillance, and I'll proceed with caution with active surveillance. Yeah.
Got it. Now, similar to all these other tools that we use to guide our decision making in terms of frequency of biopsies, intensification of surveillance, et cetera, we're seeing more and more genomic testing products enter the market. And a lot of those genomic tests kind of market themselves with a value proposition that, like, this specific clinical scenario, intermediate risk prostate cancer, high volume, low risk prostate cancer, this is how they really help answer those tough management questions. So I would love to hear your thoughts on how genomic testing fits into this puzzle, because as we've covered, it's not really a slam dunk answer. There's a lot of nuance here.
Definitely. And there's a lot of nuance regarding the data around these commercially available genomic classifiers and active surveillance. Certainly in studies of patients that were treated for their prostate cancer, such as the Decipher genomic classifier that was looked at in several NRG and RTOG trials, it seems like these genomic classifiers are fairly good at predicting a 10-year distant metastases rate. If the score is really low, then the risk is going to be low, whereas if the score is very high, then the risk is going to be much, much higher. And we know from real-world data that these genomic classifiers really do change management in our patients with localized prostate cancer. Specifically in active surveillance, though, I think we still need more studies that are done in patients that are completely unselected. So a lot of the studies that we see out there are, yes, in active surveillance patients, but this was what we call opportunistic testing. So these patients had a reason to get these genomic classifiers done. So they probably were higher risk to begin with. Now, in those patients, it does seem to predict outcomes after active surveillance. But I think, like I said, we need to do these studies in more unselected active surveillance patients to understand better what is the role. And then we also need to do modeling studies where we add these genomic classifiers to our complex clinical models that include all the information we already have, and especially cribriform and introductal, because there are a lot of people out there that think that maybe these genomic classifiers are essentially just capturing that. So if these tests are obviously very expensive, or if they don't have added value over what we already know, then that doesn't argue to using them. Now, in actual practice, and even in my practice, I have to recognize I use these classifiers, and I do notice that they change management. I have certainly seen patients with grade group 2 disease, small volume pattern 4, and a really, really high Decipher score. How can one ignore that? Yeah, it makes me really wonder if the underlying biology of the cancer is much worse at the molecular level compared to what is visible on H&E. So do I use them? Yes. How much they should be used? We still need to answer that. I do like to stress to the patient that these genomic classifiers are only based on one biopsy core. And we don't even know which biopsy core to use. Maybe it's the targeted biopsy core, but maybe not. And we know that prostate cancer is very heterogeneous within a single prostate and even within a single tumor. And it would be, I think, too expensive to basically do the testing on every single core. Oftentimes, you don't even have enough cancer in every single core to do that. And so there are other techniques to do tissue-based testing that we could consider using in the future. So, for example, artificial intelligence, using digital pathology. The testing that we have currently commercially available is also based on only one core, but it would make sense to just do every single core, I think. Hopefully we can do that in the future. or maybe P10 loss. P10 loss, I think, has been shown on multiple studies to be really a strong predictor of bad outcomes. And immunohistochemistry on every single biopsy core certainly is a lot of work, but less than doing DNA or RNA extraction on every single core. So that's also something we could consider in the future.
Yeah, and just for completeness sake, I mean, you mentioned Decipher, you referenced Artera, AI, prostate analyses. What other commercially available products are out there?
Yeah, so there are other RNA, DNA-based testing such as the Oncotype or Polaris, and there haven't really been great, I don't think, head-to-head comparisons and the results of these are very mixed. And also we're today talking about intermediate risk patients. And so a lot of the studies are based on all active surveillance patients, which the majority are low risk. And then for the AI reads, yes, there is the multimodal artificial intelligence tool that Artera provides that has been tested in other radiation therapy clinical trials, but not specifically in active surveillance. So we definitely need to do more research in active surveillance cohorts. And of course, there are a bunch of other AI companies that are currently trying to develop algorithms for active surveillance. There's also companies that are looking into MRI reads. We know that there can be big discrepancies between MRI reads. Sometimes you can have a PIRADS 5 patient get downgraded to PIRADS 2, and so maybe AI will help limit those misclassifications on MRI. And actually going back to digital pathology one more time, there are also a lot of pretty reliable algorithms for simple Gleason scoring, which I think, obviously is not as exciting as a MMAI type tool that predicts progression or some other oncologic outcome. But you and I, we both work in academic centers, so we're very lucky to work with GU pathologists. But having access to a GU pathologist through an AI algorithm, I think, is very exciting. And several studies have shown that these AI reads can provide reads that are at the level of a GU pathologist. And so I think that'll be really important for active as well.
Yeah. We've talked a lot about the specific cancer biology, the clinical data we have available, but let's now talk about what I think is actually the most important aspect of this clinical scenario, and that is patient counseling, because I think it has a profound impact on the decision that the patient makes. Ultimately, it's all shared decision making. There is no right or wrong answer here, and active surveillance is an equally reasonable option as compared to active treatment. So tell me, how do you start out by framing this conversation in a patient who may be pretty anxious, actually? Like, it's another day in clinic for you and I, but this may be the worst day of this patient's life.
Yeah, great points. I mean, exactly like you said it, it's considered currently an option for intermediate risk patients, unlike low risk, where active surveillance is clearly stated in our guidelines as the preferred option. So as of right now, for intermediate risk patients, it's just an option. I think it's important for the patient to know that they can't go wrong. No one will fault them or the provider for choosing active surveillance over active treatment. And I think that's really important, especially for the anxious patient. Then in terms of active surveillance, I think it's important to counsel them on their risk of progression and just overall oncologic outcomes that they can get. And if they have any of those risk factors that we mentioned earlier that potentially makes them a borderline active surveillance patient, they really need to understand and that their risk is going to be higher than the average active surveillance patient. Yeah. Now, I don't tell them that means they can't do active surveillance. Sometimes I'll frame it as, well, it's not really a matter of if we're going to do treatment, but when we're going to do treatment. Because any time on active surveillance, in my mind, is a win, because that's time without the side effects of treatment. And so if we can safely monitor a patient for even just a couple of years, and then the patient undergoes a radical prostatectomy or radiation, I think that's great, as long as they have similar oncologic outcomes than the patients that chose upfront treatment. They need to be committed to follow up, so I definitely need to tell them from the very first day what they should expect. And so that protocol that we mentioned earlier, how regular they're going to need to get biopsied, because of course these poor patients, they just underwent a prostate biopsy. You're already talking to them about getting another one. They need to be willing to undergo that and all the other monitoring that goes with it, and not forget about their cancer because these cancers obviously can progress. In terms of patient anxiety, I think a lot of the anxiety also comes from the provider. And for low-risk patients, I think now we have such strong data that supports active surveillance. It's easy for us providers to not have any anxiety around active surveillance, but I think it's not as easy for intermediate risk. I mean, there are so many patients that are kind of borderline, we don't really know. And so while on the one hand, I don't want to transfer anxiety to my patients, on the other, I want to be completely honest about everything I'm thinking about. And so if I'm telling them, look, I'm not 100% sure, let's continue monitoring. And I tell them to try to reassure them, let's give this cancer some time to tell us what type of cancer it is, to tell us what its true biology is. And sometimes that I find that helps reassure the patient that this is just like a temporary thing. And if it's looking like it's progressing based on PSA or anything else, then we're not going to hesitate and we're just going to go ahead. And I think when when I really, tell them everything that I'm thinking about, like in that way, it can help reassure them that we're a team, we're in this together, and we're going to make sure that we do what's safe.
Yeah, I totally agree. I use that strategy too. And I'll say things like, this is not a commitment. We can, the nice thing about choosing active surveillance is we can change our strategy. If you go home later today and you say, you know what, I feel really uncomfortable with this, I want to proceed with active treatment, no problem. We can pivot. Or if we get more data in the future that swings us one way or another. So I think that's a great point. In terms of the conversation as it relates to counseling regarding long-term outcomes and metastatic risk, you covered the PROTECT data as we started off this conversation. Is that what you use in your counseling, or are you referencing some of these other studies? Again, probably more centered in the low risk space, but what can we extrapolate and what's more relevant for this population?
Yeah, I mean, the short answer is that essentially really long-term prospective data. When I say long-term, I'm talking about over 10 years, looking at the risk of metastases and death in intermediate risk patients managed on active surveillance, it's very limited. So some of it is extrapolating from PROTECT, and then there are other studies that have synthesized multiple studies that are more what we consider more contemporary, so in the 2000s and beyond, as a lot of these studies have used MRI. And I will quote that so far, it looks like the risk of prostate cancer-specific mortality and metastases is very, very low, similar to low-risk patients in those patients that have grade group 2 prostate cancer with low PSA density, overall favorable factors. But essentially we need to wait a little bit longer to get prospective active surveillance data.
Yeah, and speaking of which, what are you most excited about in the future as more and more people are thinking about this question? Are there studies that are ongoing that you're looking forward to being able to guide some of these conversations in the clinic?
Yes. There's a lot of exciting research, I think, going on. PSMA PET-guided biopsies. There are several studies going on right now. I'm very excited to see the results of them. Maybe they will help with misclassification. And we know that misclassification is a big deal in active surveillance patients. And so if we knew from the get-go exactly what they have, it'll help us, determine better what the plan should be for them. Other things that I'm excited about, the role of better understanding the role of germline genetics. And this is a personal interest of mine, so maybe that's why I'm very excited about it. But there are essentially only 2 studies that have really looked at rare pathogenic mutations such as BRCA2, 1, ATM, and outcomes in active surveillance. One is from the Hopkins group and the other one is from the Canary Pass group, and they're conflicting. And so that is definitely something I'm looking forward to digging in more into in the future, because especially for these intermediate risk patients, is active surveillance even safe for these patients? We really have no idea. Family history and polygenic risk scores are other measures of inherited risk that also, I think, warrant more investigation in intermediate risk patients. And so I'm excited about more data coming out in that space. And then there's a lot of liquid biomarkers that are developed for prostate cancer, the diagnostic space. And some of them have already been tested in active surveillance, but there are multiple that are coming out, such as the My Prostate score. The Prostate Health Index is certainly not new, but we're actively doing research on it in Canary Pass. And when I was at Hopkins for my fellowship, we did research on the Prostate Health Index too. And, it makes sense for these markers, in my mind, if they are more specific for higher grade disease in the diagnostic space, then they should be more helpful than PSA in active surveillance. And so I think more research is going to come out on those liquid biomarkers, and hopefully they'll be very helpful in risk stratifying our patients. So those, I think, are some of the things I'm personally most excited about for the near future.
Yeah, I think the liquid biopsies are really, really interesting, right? Because we didn't cover this, but let's not forget, one of the big reasons patients opt against active surveillance is the need for repeated prostate biopsies.
100%.
It is not something they enjoy. There are side effects: transient erectile dysfunction, the discomfort of having blood in your urine, semen, stool, the pain if you're having it in the office, the fact that it's just an uncomfortable, anxiety-provoking experience, and so I think looking to the future, I get really excited about the fact that we are trying to better diagnose prostate cancer better, more accurately, I'll put it that way, but also with less invasive, less uncomfortable techniques. Because I think the elephant in the room is that it is, in its current form, it is really not the most patient-centric experience.
100%, yeah. Avoiding biopsies as much as we can is really an important goal. And also, we talked about all of these complex risk factors, and they can, in theory, all be included into a very complex risk calculator, and several groups have published on these risk calculators, but there's so much nuance, as we discussed, on how to quantify all of these different variables, such as pattern 4, volume. And then there's misclassification issues like we discussed, such as, discrepancies between pathology reads and radiology reads. If we could have a simple liquid biomarker, just one number that does all of that in one number, that would be the holy grail, I think, for active surveillance patients.
Yeah, absolutely. Couldn't agree more. So as we wrap up here, what are your big takeaways for the audience? People who are listening who may not routinely recommend active surveillance for intermediate risk patients. What's your message to them?
My message is for the really low volume pattern 4, so group 2 patients with low tumor volume, low PSA density, non-concerning PSA candidate, relatively stable MRI, or non-concerning MRI, I think active surveillance really should be considered in those patients. We didn't really talk about this, but there are some really great genomic studies out there that show that subset of grade group 2 patients at the genomic level is essentially the same as low risk. And so that kind of biologically confirms what the studies we mentioned earlier show, that those patients have the same outcomes. And so I think we really need to get that message out there, that there are some intermediate risk patients that are great candidates for active surveillance. The questions really are around the patients with more pattern 4, consistently rising PSA, high PSA density, concerning MRI findings, concerning genomics. We really need to do more research in that space. And in that space, if the patient's very anxious, if the provider's anxious, I don't think we should fault anyone for seeking treatment, active treatment in that setting. So I think at least we have clear indications for surveillance in the really low risk grade group 2 patients. Yeah, and in everyone else, then we still need to do some research.
Yeah, but you know what? I'm so glad we're even talking about this, because a decade ago, active surveillance in general, let alone for intermediate risk patients, was out of the question. So we've come a long
100%.
way. I am excited to see where the field goes, and I'm really thankful that you spent some time sharing your expertise with us.
Thank you so much for having me.
And to our audience, thanks for joining us. We hope you'll tune in next time. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon.
with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.